Hello everyone, and welcome to today's webinar on ICD-10-CM Codes for TBI, offered by the National Association of State Head Injury Administrators. I'm Carrie Bennett, Chair of NASH's Training and Education Committee. Thank you so much for joining us. If you're not familiar with NASHA, we are a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. Before we begin, I have just a few housekeeping details. A GoToWebinar user guide is available for download from the NASHA website. This is a great resource for making the most of your webinar experience. An online GoToWebinar help button should all noise. All attendees' microphones will be muted during the presentation. However, you may submit questions for the presenters at any time by typing and submitting them in the question text box on your GoToWebinar toolbar. Any questions that are not answered during today's webinar will be answered later via email. Our objectives for today are to introduce you briefly to the ICD-10-CM, describe how the proposed ICD-10-CM surveillance definition was developed, and discuss testing and preparation for the new proposed TBI definition. Our presenters today are Matt Briding, Chris Taylor, and Holly Hedegaard. Matt Briding is currently the TBI team lead in the Division of Unintentional Injury Prevention at the CDC's National Center for Injury Prevention and Control. Prior to coming to the TBI team last year, he worked in the CDC's Division of Violence Prevention, where he focused on surveillance of intimate partner violence, sexual violence, and child maltreatment. Chris Taylor is an epidemiologist on the TBI team in the Division of Unintentional Injury Prevention at the CDC's National Center for Injury Prevention and Control. His work involves developing national estimates of TBI morbidity and mortality. And Holly Hedegaard is an injury epidemiologist in the Office of Analysis and Epidemiology at the CDC's National Center for Health Statistics. For the past 3 years, she has been engaged in CDC's efforts to prepare for the transition to the ICD-10-CM, particularly as related to injury. And now I'd like to welcome Matt Briding.
Thank you very much. Good afternoon, everyone. I'll be very brief. I just wanted, before we start the webinar, to thank Holly and Chris for their leadership. Holly leading the effort to update the ICD-10-CM codes for all of injury, and to Chris and also Victor Coronado on our team, who worked with her to update the TBI codes. The codes that we're going to be discussing today are really the basis of our national TBI surveillance, and so they're of great importance to us. And I also know they're of great importance to the states as well, because they're used for a variety of purposes, one of which is surveillance in the states. And so this is a really critical effort, and we're happy to share the work that has been done getting us to this point. And so with that, I'll just turn it over to Holly and Chris to begin the webinar.
Thank you. This is Holly Hedegaard, and I appreciate this opportunity to share with you our proposed surveillance case definition for traumatic brain injury using ICD-10-CM. Can we move to the next slide, please? The discussion today is actually going to be focusing on a surveillance definition for TBI, and so before we get started, I really wanted to make sure that people understood that we're making a clear distinction between what's a clinical definition of a traumatic brain injury and what's a surveillance definition of a traumatic brain injury. Clinical definitions are used when it comes for physicians to diagnose a patient with a particular condition, and so clearly they're going to be observing the patient and noting a lot of different things before making their diagnosis. What we're going to be talking about today is what's considered a surveillance definition, And a surveillance definition is typically one that's used by epidemiologists and researchers, so it's a little bit different environment. And a lot of times, epidemiologists and researchers are working with electronic data sets that have coded information. And so the surveillance definition is one that is meant for analysis of data that's coded using the clinical modification of the International Classification of Diseases. Now, I know spending a minute just talking about what is this international classification cause in the U.S. and compare it to death to a certain cause in another country, we're talking about ICD. And in addition to the ICD itself, which is typically built for use with mortality or death data, lots of countries have chosen to also develop what are known as clinical modifications. And those are similar codes that are used for looking at usually non-fatal cases. So it would be for emergency department visits or hospitalizations, that type of thing. And so typically if you see an extension CM, that means it's a clinical modification. In the US, when it comes to the codes for mortality or death, we used ICD-9 from 1979 to 1998, but since 1999, we've been using what's known as ICD-10. When it comes to the morbidity or the non-fatal cases, we're still using ICD-10-CM. We've been using ICD-10-CM since 1979, but there's a big transition that's coming up at the end of this month, beginning October 1st, where hospitals and clinics and physicians' offices are going to be required by the Centers for Medicare and Medicaid Services to use a new coding schema, which is the ICD-10-CM. So when you have all these different versions of the ICD, when you're coming up with case definitions, then you have to create a new case definition in every single one of these different types of versions. So as mentioned here on the slide, we've been using ICD-10 for deaths and ICD-9-CM for morbidity cases. And in both of those worlds, we've developed definitions for traumatic brain injury that have been in use for over 20 years. So in the next few slides, I want to briefly look at the existing surveillance definitions for TBI. So the first one is the ICD-10-CM codes that have been used for TBI morbidity. And just a couple things I wanted to point out here. First, if you look at the column that's labeled ICD-10-CM code, you'll see that the numbers here are codes within the range of 800, 959. Those are the types of structure of the codes that we're looking for. And these particular codes are the ones that have been identified to help identify traumatic brain injury. So you can see that they include skull fractures, intracranial injuries, concussions. We've also included some codes for injury to the optic nerve, a specific code that was for shaken baby syndrome, and then the 959.01, which is head injury unspecified. In the next two slides, I'm going to be talking about the codes that were selected for TBI-related deaths. So because it's death, the coding structure now is ICD-10, not ICD-9-CM. And when you look here, again, if you look at that column that says ICD-10 code, you'll see that the structure of the code looks entirely different. Instead of those numbers of 800, 950, 959, we now have codes that start with the letter S. And that's because in the ICD-10 coding structure, injury diagnoses all start with the letter S or the letter T. Another couple things to sort of note on this slide. On that very first row, SO 1.0 to SO 1.9, the description here is for an open wound of the head. And you might recall that on the 9-CM definition for morbidity, that particular concept wasn't included. So part of the reason for that difference is because when these codes are assigned to the information on the death certificate, a lot of times the information on the death certificate isn't nearly as detailed as that in a medical record in terms of the diagnosis. So for example, sometimes on a death certificate, if it was a suicide and it might have been a gunshot wound to the head, there's not a lot of detail of all of the anatomic injuries, and it'll just say open wound. And so when you see that word open wound on a death certificate, it can have a different meaning and therefore might be more relevant to traumatic brain injury on a death certificate than it would be in a medical record. The next slide continues with the codes that are included in the TBI mortality definition. I use two slides here just because if you try to put them all on one slide, it's just too small to be able to read. These are another series of codes that are still included in the TBI mortality definition. These codes all start with the letter T. There are several codes here, the T01.0, T02.0, T04.0, and T06.0. Those codes are actually used in an international definition, and for comparability, we've included them here. But the reality is these types of ICD-10 codes are not used in the United States. In the United States, we recommend that for these combinations that involve injuries to both the head and the neck, that the head injury code be coded separately from the neck. So that's why these codes aren't used here in the U.S. You'll also see in that final row that there's several codes that involve sequelae of head injuries. And what that means is that the head injury might have happened in the past and the person died years later of some consequence of that head injury. Next slide, please. So why do we need this new surveillance definition? Well, as I mentioned, the U.S. is going to be moving to ICD-10-CM beginning on October 1st. And so for every version of the ICD that's out there being used, we need to understand what are the best codes to use in each individual coding system to help define the types of cases that we're looking at. In addition, it's also a nice opportunity to consider whether or not the concepts or the decisions that we've made in the past about the TBI surveillance definition, do we want to continue those? Do we need to modify them in some way? Do we need to think about new things that have come up that ought to be taken into consideration? So before sort of talking about the work that was done to come up with the new definition in ICD-10-CM, I wanted to spend just a minute talking about some of the differences between ICD-9-CM and ICD-10-CM for head injury codes. So 9-CM and 10-CM are both coding systems that are used for morbidity. So they're used for non-fatal events, emergency department visits, clinicians' office visits, hospitalizations, that type of thing. So some of the differences between 9-CM and 10-CM, and for those of you who are epidemiologists or who work with coded data, you'll be familiar with some of these concepts. In 9-CM, some of the skull fracture codes also include, part of their description includes an intracranial injury as well. This is different in ICD-10-CM. In ICD-10-CM, there's no combination codes like that. There's individual codes for skull fractures and other separate codes for the intracranial injury part. So we no longer have to worry about this issue of the combination code that was present in 9-CM, because in 10-CM, each of these items, skull fracture and intracranial injury, are completely separate. The other thing that's new in ICD-10-CM is that for some of the intracranial injuries, and in particular SO6.3, which is a focal traumatic brain injury, it specifies whether or not that injury happened to the right side of the brain or the left side of the brain. So again, more detail, more information available in ICD-10-CM compared to ICD-9-CM. That's also reflected in other codes that provide, again, more detail. An example I give here is SO 6.8, other specified intracranial injury. But in the subcategories of other specified intracranial injury, there's actually specific codes that go down to the level of detail of identifying injuries to the intracranial portion of the internal carotid artery. So again, rather than having a very broad category, other specified intracranial injury, there's actually more specific codes embedded within that particular class. Another thing I want to spend some time on is looking at the modifiers for a loss of consciousness. And in ICD-10-CM, there's many more categories than were available in 9-CM, and I'm going to show you those in just a moment. But I think there are some implications with regard to how ICD-10-CM might be used to identify minor traumatic brain injury. And then finally, one of the other big differences between ICD-9-CM and ICD-10-CM is that this loss of consciousness modifiers are only used for the intracranial injuries. In ICD-9-CM, skull fractures also had these loss of consciousness modifiers added to them. That's not the case in ICD-10-CM. In ICD-10-CM, the skull fracture codes do not include those modifiers that describe the loss of consciousness. So what do I mean by these modifiers? So what these modifiers are actually a digit within the code that tells you something about the loss of consciousness and the length of time of loss of consciousness. So this table shows you what those modifiers look like in ICD-9-CM and then what they look like in ICD-10-CM. So in ICD-9-CM, there actually were 8 particular modifiers, and if you look over them, you'll see that they talk about brief, moderate, and prolonged, but they're rather long periods of time. So for the brief loss of consciousness, less than 1 hour, moderate loss of consciousness 1 to 24 hours, and prolonged as being greater than 24 hours. So a lot less specificity in 9-CM compared to 10-CM. If we look over there on the column that's labeled ICD-10-CM, you can see that there's even more categories available. So loss of consciousness for 30 minutes or less, 31 minutes to 59 minutes, and so on. So you have much more capability of capturing shorter periods of loss of consciousness. The other thing to note on the ICD-10-CM column, if you look further down to the, not the last bullet, the 3 bullets before the last bullet, there's a distinction made between whether or not the person died from a TBI or they died to some other cause, even though they had a TBI. So again, a way of identifying different types of patients, different types of traumatic brain injury, and whether or not that traumatic brain injury actually led to the death, or if the person died from something else, even though they might have had a minor traumatic brain injury. So again, more detail provided in ICD-10 compared to ICD-9. So with that background, I'm going to shift now a little bit and start talking about the work that was done by our work group to start thinking about this ICD-10-CM surveillance definition. And here are the people who participated in this work. We took about a year to accomplish all of this, and all of these people deserve credit for participating and providing their great ideas in terms of coming up with the proposed definition that we'll show you in a bit. So as we started our work, one of the things that we needed to do is sort of think about our approach. And so in the next slide, I just wanted to highlight a few things that sort of influenced our thinking when it came to starting our work on this traumatic brain injury definition. And one of the things that we wanted to try to keep in mind was coming up with a definition that would be relatively comparable with the ICD-9-CM surveillance definition that I showed you earlier and the ICD-10 surveillance definition for TBI death that I showed you earlier. So, even though there was an ICD-10 surveillance definition for TBI death, we decided not to just sort of blanket accept that definition as the definition for TBI morbidity. And there's some reasons for that, which Chris will go into in a moment. The other thing that we kept in mind as we were working is that we decided, at least initially, we would only look at those injury diagnosis codes that are in Chapter 19. So those are the codes that start with an S or a T. There are other codes in the ICD-10-CM world that talk about signs and symptoms. And so sometimes it's a Glasgow coma score. There's other things about temporary loss of consciousness, that type of thing. But those are signs and symptoms. They aren't really a full injury diagnosis. So for the purposes of this initial proposed definition, we made the choice to only use those injury diagnosis codes that were in Chapter 19. So all of the codes that you'll see that we propose start either with the letter S or the letter T. Another thing that we had to keep in mind as we started working on this definition was another aspect of a change in the coding structure that came about in ICD-10-CM. And so in the ICD-10-CM world, the codes have up to 7 characters. And the 7th character typically describes the type of encounter. So what type of visit was this? Was this an initial visit? So this was the first time the patient was seen for this condition by this particular care provider. Was it a subsequent encounter, meaning if somebody broke their leg and had a cast put on and they came back to get the cast taken off, that would be considered a subsequent encounter. That is, the person, the person wasn't being seen for initial treatment, but rather for follow-up care for an active injury. And then there's also what they call sequelae, which are sort of the long-term impact of a given injury. So when it comes to thinking about our surveillance case definition, we needed to be mindful of, are we going to include all of these different 7th characters or only just some of them? And a lot of that has to do with whether or not we're looking for an incidence-based definition as opposed to a prevalence-based definition. So in an incidence-based definition, we're trying to identify how many new cases happened within a period of time. Whereas in a prevalence-based definition, we're trying to identify anyone in the population who might have a given condition. So with these different choices for the 7th character, it provides some aspect of trying to think about, was this an initial brand new TBI, or is this a TBI that has been in existence for some period of time, and this is either a follow-up subsequent encounter or a sequelae of the TBI. So with that background in mind, I'm going to switch over now to Chris, who is going to describe for you how we moved forward with our process of developing the ICD-10-CM proposed surveillance definition for TBI. So Chris?
Thank you, Holly. This is Chris Taylor at CDC, and so as Holly said, I'm going to talk about, how we came to this definition, sort of lead you through the process that we followed. And I wanted to start with one of the tools that we use to create this definition, something called a general equivalence map, or GEMS. And so this is a code-to-code reference that provides sort of, possible translation of codes from ICD-9 to ICD-10-CM and back from ICD-10-CM to ICD-9-CM. If you are familiar at all with medical coding, you may be familiar with the term crosswalk. Like if you're coding something from the DSM-4 or 5, you can crosswalk those codes into ICD-9-CM. But we avoid using the term crosswalk because it implies a one-to-one match between ICD-9-CM codes and ICD-10-CM codes, which, as you'll see, is not always the case. And it's usually not the case with the revision in ICD-10-CM. And there's a couple reasons for that, some of which Holly already touched on with some of the changes in loss of consciousness coding, as well as there are some new concepts in ICD-10-CM that don't have a predecessor in ICD-9-CM. things like underdosing or Glasgow Coma Scale. And so you couldn't, there's no one-to-one match between a Glasgow Coma Scale and ICD-10-CM to ICD-9-CM. And so I'm going to go through some examples in some subsequent slides. So if you're interested, you can find the ICD-10-CM GEMs online at the cdc.gov website. We have the link here, and they're listed right there, and you can download them and go through them if you'd like. So I'd like to sort of show an example of using the GEMs, where we would go from an ICD-9-CM code to an ICD-10-CM code. And in the box on the left, the example we have is ICD-9-CM code 800.22. And that's the
Chris?
slide that, yes?
This is Maria. I'm sorry to interrupt you. So sorry.
Okay, so the example we're going to, sure. The example we have is 800.22. It's a closed fracture of the vault of skull with subarachnoid, subdural, and extradural hemorrhage with a brief loss of consciousness defined as loss of consciousness less than 1 hour. And so there's no equivalent, there's no one-to-one match of this ICD-9-CM code into ICD-10-CM. So when you look up this code in the GEMs, you're directed to 7 possible code matches. And I'll go through these ICD-10-CM codes to explain why. Have a hemorrhage, subarachnoid, subdural, or extradural hemorrhage diagnosis, and you have a loss of consciousness identifier. So according to the GEM, this case would be coded with at least 2 different codes, one for the fracture and one for the hemorrhage. And so you can see on the right, code S02.0 would be the fracture of the vault of skull with a closed fracture. But then you still have to have additional codes for the loss of consciousness and the hemorrhage. And that's actually the next 6 codes that are listed. So for example, the next 2 listed, S02.4, both of those codes are for epidural hemorrhage with a loss of consciousness of 30 minutes or less, or a loss of consciousness of 31 to 59 minutes. So you can see then those same examples follow through for SO6.5 for the traumatic subdural hemorrhage, as well as SO6.6 for the traumatic subarachnoid hemorrhage. So you can see that it wouldn't be a one-to-one match. You would have to, in ICD-10-CM, to code this equivalent diagnosis, you would code first the fracture, and then the specific hemorrhage with the appropriate amount of loss of consciousness. And you can see from this, as well as from Holly's earlier examples, there are more discrete amounts of loss of consciousness with ICD-10-CM. You can also go backwards from ICD-10-CM to ICD-9-CM. And one of the examples on this would be if you look at code in ICD-10-CM, S06.1, it's a traumatic cerebral edema without loss of consciousness. There would be 2 equivalent codes in ICD-9-CM, one for cerebral edema and one for intracranial injury without a mention of intracranial wound and with no loss of consciousness. So the ICD-10-CM makes it possible to code traumatic cerebral edema in a way that was not possible in ICD-9-CM because cerebral edema, the 348.5 code, was not an injury code. So the recommended process for using the GEMs is defined on this slide. And this is the process that we used. You start with the ICD-9-CM case definition codes, which which we've been using, as Holly discussed, and we use that to find possible comparable ICD-10-CM codes. And then additionally, work backwards and look at ICD-10-CM codes to identify other ICD-9-CM codes. And that way you have sort of a complete list to look at and, go, is this what we want? Do we believe, at this initial stage, are these things that generally would describe traumatic brain injury in a clinical setting? And so we'd review all of these codes. The next step would be to test sensitivity and specificity using a gold standard, and then come up with a final ICD-10-CM case definition. And we'll talk a little bit about those next steps later on. And so some of the results of what happened is when we took the GEMS and applied it to the ICD-9-CM surveillance definition for morbidity, there were 493 unique codes in the ICD-9-CM code definition for traumatic brain injury. And using the GEMS, that resulted in 221 unique ICD-10-CM codes. Of these 221 unique codes, 220 of them are included in the ICD-10 definition for mortality. So that's the ICD-10, not the ICD-10-CM. And that one code is T74.4, shaken infant syndrome, which is not found in the mortality definition. There are ICD-10 codes in the mortality definition that are not included in the ICD-10-CM morbidity definition, and Holly had referenced those earlier, things like fracture of the facial bones, open wounds of the head, that generally are not considered indicative of TBI in living persons when that code is presented alone in the record, but do suggest TBI in a death certificate report. So some of the caveats of our ICD-10-CM definition is this is just a draft definition. Everyone who worked on this worked very hard, but the fact is we don't have the ability yet to assess the sensitivity and specificity of these codes because there's no data yet available. As Holly had mentioned, this definition does not go into effect until October 1st of this year, so 2 weeks to go. And so we won't even have a full year of data collected until the end of 2016. And so until we receive that data, hopefully sometime in 2017, we won't even have any data to compare previous statistic numbers. There's no sort of standard for which to compare this definition to yet. So on this slide, this is our draft proposed ICD-10-CM surveillance definition for traumatic brain injury. And you can see there's 6 different categories of diagnoses here. Skull fractures, which is the SO2.0 and SO2.1. Fracture of other specified skull and facial bones or unspecified fracture of the skull. Those are codes SO2.8 and SO2.91. Injuries of the optic tract and pathways, as well as the visual cortex. Code category S06 is intracranial injury, so that would include everything labeled as a concussion. S07.1, crushing injury of the skull, and then T74.4, the shaken infant syndrome. And if you would, note the footnotes at the bottom here with the use of the dash, which indicates any 4th, 5th, or 6th character. And then obviously, these are the categories of codes. But as I mentioned before, there's 220 individual codes. And then, of course, as Holly mentioned, there's the option of the 7th character of A or B for the skull fractures, which would indicate an open or closed fracture, which is an initial encounter. And then the 7th character of A for the remaining codes, which would simply indicate an initial encounter. Because, as again, we had mentioned before, we're interested primarily, at least here at CDC, in examining TBI incidents. But know that codes for subsequent visits and sequelae are possible within ICD-10-CM. So we also, in case you're interested, this slide shows the codes that are included in our ICD-10 TBI mortality definition, but these are not included in the ICD-10-CM morbidity definition. And we've mentioned these a couple times already, things like open wound of the head, crushing injury of the face, or sequelae injuries of the head, things that would be more likely to show up on a death certificate as indicative of a traumatic brain injury than in a hospital or other type of medical record. So those of you who are sort of familiar with TBI statistics as they relate to the use of these diagnostic codes may be familiar. One of the codes that is included in CDC's surveillance definition is code 959.01, which is an unspecified head injury. And there's an equivalent code in ICD-10-CM S09.90. And at this point, we've decided that this unspecified head injury code is not included in this draft ICD-10-CM code definition for TBI morbidity. A couple reasons for that. There was a study that found about 75% of ED records with code 95901 did not meet the clinical criteria for TBI. And if you look at the history, when ICD-9-CM was first created, code 95901 was not part of that initial release. But at some point, it was created in response to the misuse of an intracranial injury code, 854.00. And so obviously the use of that code went up while the use of 854.00 went down. But we're sort of hitting the reset button moving into ICD-10-CM. And we've decided at this point not to include this ICD-10-CM equivalent. But when we look at the sensitivity and specificity of this code, as we move forward with additional data, obviously we want to look to see whether we want to continue to exclude this code or we want to eventually include it in our definition. And so for the next steps, we have had this definition reviewed by our partners within federal agencies, and if anyone here on the call has any comments, we'd be glad to hear them, because as we've said, this is a draft definition, something that obviously we're not going to know how it's going to be used until the coding starts, until questions occur. Additional codes were added to ICD-9-CM throughout the years. And so this is, there's a possibility for this to be a fluid definition, especially because we don't know the utility of this definition yet with respect to how it meets a gold standard of traumatic brain injury as a surveillance definition. So we want to test some coded data using ICD-10-CM, and other possibilities are explore codes other than those found in the injury diagnosis chapter. One of the other possible next steps we've talked about is developing a mild TBI definition, similar to the one found in the 2003 report to Congress. And that was the last slide I have, and I hope there are a couple questions out there, and we'd be happy to answer some of them now. And I have our contact information up here on the last slide too, in case you want to contact Holly or I separately. If you think of a question after the call, we'd be glad to help you.
Chris, there are a few questions that we could run through. Several of you have asked about whether or not you can access the slides at a later time will be shared, and CDC is awaiting approval to release these slides, and once that is received, we can post the actual webinar, the audio piece, as well as the slides for you guys to go back and have. That'll be on. A few folks asked if you could go back to the one screen, I think it's slide 14, that shows the website. I posted it in the questions log, but I don't know if all of you can see that. There it is. While you guys are jotting that down, I had a question from an attendee. What about anoxic brain injury that's due to a trauma, such as a near drowning or attempted hanging or severe blood loss?
Chris, I can speak to that a little. Generally, we have not included anoxic brain injuries in our definition. That depends on a variety of factors, including sort of, the work that CDC does is based on funding through statutes. And so if we've classically included over the years things like spinal cord injury, in addition to anoxic brain injury, in addition to traumatic brain injury, but the traumatic brain injury due to injury mechanisms such as falls, motor vehicle crashes, things like that, outside of anoxic brain injuries, even if they're due to trauma, we have not included. We don't typically do work on those, but obviously as policy changes, we would address that if we were directed to. I don't know if Matt or Holly have anything else to add.
Well, this is Holly, and the only other thing I was going to mention is that for some of those things that you were talking about in terms of blood loss and things that aren't sort of an anatomic injury per se, they aren't included in the injury diagnosis chapter. So again, one of our decision-making caveats at the very beginning was to stick with those codes that are in Chapter 19, which are the injury diagnosis codes. So that was also part of why we've chosen this set of codes at this stage. And as Chris has mentioned, once we have data to look at, we can see whether or not this definition needs to be modified or expanded so that it would include other kinds of codes. At this point, this is what we're recommending. And again, it's based primarily on anatomic changes.
Great, thank you. This is a question for all of you. Will there be a follow-up webinar on this topic when more of the data becomes available? That would be very helpful. Are you guys amenable to that?
This is Matt. I can certainly speak to that. I think, yeah, that would be. We would be happy to do a webinar once we have some data and can provide some more guidance in terms of what we currently think are the appropriate codes given the data. So that would be no problem at all.
Great, great, thank you. Next question. What is the difference between the S and T codes? Sorry if I missed this at the beginning. Do those S and T letters stand for anything in particular, Holly, or is it arbitrary choice?
So the difference between the S and T codes are the T codes tend to look at things that are in more than one body region, or they look at things that are across the body. So for example, all of the poisoning codes start with the letter T because it is sort of located to any one body region. All of the S codes have to be assigned to a body region. So that's why some of those T codes that you saw that were in the mortality definition, the ICD-10 definition for death, they were codes that were injuries to the head and neck. Well, because two body regions were involved, that's why they got a T code. The same thing with the sequelae. So that's why they're a T code. So the S codes typically are assigned to a single body region. The T codes are either to more than one body region or something that's sort of system-wide. So that's the differentiation between S and T.
Great, thank you. Next question, the 959.01 code has caused great confusion and overuse when some patients actually meet condition diagnosis. I believe a better and more defined definition is warranted. Any thoughts on that?
This is Chris. Just a couple notes. I mean, obviously we can, as we've seen the use of this code rise, it calls into question its validity. Though I guess one thought too is it's sort of a multi-component issue that has to do with how the code is used, who's assigning the code, whether a diagnosis is made at the time and that's properly coded, or whether whoever is doing the diagnosing, whether the physician has decided to either consciously or unconsciously not call an injury a concussion. And I know there have been studies that have gone back and said, these codes, sometimes when you look at these charts, they're coded with an unspecified code, but they do meet clinical criteria, and sometimes they're coded unspecified and they don't meet the codes of the clinical criteria. And then also we know that there's an issue if you might have someone who's a very young child who's injured, someone under 1 year or 2 years old who comes in after a fall from a table or from a high chair, for instance. There's no great way to diagnose concussion in that group. There's no test that can be done. And so sometimes 950-901 is used because there's no other way to say this child has a head injury. I can't say it's a concussion, but they did come in and seek care for head injury. And that's the other thing, is sort of the drawback of using these administrative healthcare codes is, these are assigned primarily for billing purposes, and we're using them for surveillance. And so we're sort of at the mercy of, how the medical care system operates.
Okay. Thank you. The next question is...
No, there's a totally different coding structure. There are lots of codes that start with E. You have codes that start with VWX, Y, VWX and Y, yeah. And the E codes, people get accustomed to using that shorthand terminology of E codes, but now E codes in ICD-10-CM are for diagnoses related to the endocrine system. So we need to stop using that terminology of E codes and should use the full label of external cause codes. So this structure of the external.
Okay. That may be interesting to most of the people that are on here, Holly, as any of us, are used to looking at those external cause codes. How about this? There's a couple of other just questions and statements on here, and then we could come back to that if that's all right with you.
That's absolutely fine. I'm happy to talk more about them.
Okay. Here is a comment. The American College of Surgeons also excludes anoxic brain injuries as well, such as hanging, strangulation, SIDS, and drowning.
This is Holly, and to be honest with you, I don't really know. I guess if it was for reimbursement purposes, there must be rules from the Centers for Medicaid and Medicare Services who probably identify who all can assign them. I mean, typically the codes, like in a hospital setting or in a clinic setting, are assigned by medical records coders based on the information written in the medical record or included in the medical record by physicians. And there's particular rules about what can be used as substantiating information and what cannot be. So, but to get back to the specific question, I don't know other than, I don't know specifically who has the legal authority to assign codes.
Interesting question. Okay, those are all the questions on this question log. Holly, if you want to take a few minutes and talk about external cause codes, that'd be great.
Happy to do so. So as I mentioned, in ICD-10-CM, there were about 1,300 or so codes for external cause. Well, in ICD-10-CM, there's 6 times that number. So there's over 7,000 external cause codes that are now available. So again, quite an expansion, a lot more detail when it comes to the codes themselves, a lot more structure to them. I mentioned earlier that it's the VWXY codes that are included as external cause codes. All of the V codes are the ones related to transportation. So anytime you see a V code now, you know that that injury event was transportation related. A lot of the other codes that we might be familiar with, and in particular those that might relate to traumatic brain injury like falls, that's a W code. It's W00 to W19. There are other kinds of codes that, like exposure to inanimate mechanical forces, that's like being hit by something. So for example, now in ICD-10-CM, there are lots of codes related to sports-related injuries, and you know, if you get hit by a baseball bat as opposed to getting hit by a baseball itself, there are separate codes. And not only just being hit by a ball, it depends on what type of ball. So there are separate codes for footballs, baseballs, basketballs, all kinds of different things. So a lot more detail in the ICD-10-CM. What else? I'm trying to think off the top of my head here because I wasn't really thinking of doing a lot of detail about the external cause codes. One of the things to think about when it comes to the transportation codes is that the structure of the code has actually changed quite a bit. In the past, there was a lot more, in the 9-CM world, there was a lot more emphasis on what was happening to the motor vehicle. So you know, the way that you ended up assigning a code was based on, did this car go off the road? Did the car hit a fixed object? Did it hit another car? Did it hit a pedestrian? That type of thing. In the ICD-10-CM world, the structure has been changed a little bit where the focus now is on the person who got hurt. So it actually makes it easier to sort of assign the codes in the ICD-10-CM world because most people know right off the bat who was the person who got hurt. So was it a pedestrian or was it an occupant in another car? Was it a bicyclist? Was it a motorcyclist? That type of thing. And so by knowing the person who got hurt, you can move towards the particular section of the coding manual to help identify the correct codes that you're going to be needing. And the way those V codes are set up is that the first character is a V. The second character identifies the person that was injured. And so again, pedestrian, bicyclist, motorcyclist, car occupant, bus occupant, that type of thing. The third character in the code identifies whether or not that event involved a collision with some other type of transportation. So for example, if a car hits a pedestrian and the person in the car got hurt, then you would be able to tell from the second character of the code that it was a car occupant that got hurt, and that from the third character in the code that it was a pedestrian that the car struck. So again, the structures of the codes have sort of changed a little bit, and once you sort of know the logic behind the structure of the code, it makes it much more intuitive how you would assign the particular codes.
Holly, in addition to hearing you talk about that, and of course looking in the ICD-10 manual, is there a resource that you could share where folks could see the way those external cause codes are described?
I actually have done a couple webinars about external cause coding, and one was for the American Trauma Society, and I believe that webinar might be up on the web. What I don't know is whether or not individuals need to be a member of ATS to access that on their website. But you might look at the American Trauma Society There was a webinar that I did back in July that was specific to ICD-10-CM external cause. Sorry, I don't have the URL right in front of me. I could look it up and send it to you, Maria, and if you want to distribute it at some point in the future, we could do that.
Certainly.
And
we could list that link. We could list that link on our website as well.
Okay. 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 And I think that's the only thing that I know of right up on the web. That a lot of the materials about ICD-10-CM are not specific to injury. So, a lot of times what you'll find are broad descriptions of ICD-10-CM that include everything: diabetes, heart disease, whatever. And so one of the things that various folks here at the National Center for Health Statistics, as well as at NCIPC, we've been trying to craft specific material around the injury chapters and the injury information. So, like I said, I did this webinar for the American Trauma Society. I've done a couple other webinars, and so I have slide sets that I'm willing to share as well, but it just isn't posted anywhere solid on the web that I can refer to right away.
Thanks for the information that you're sharing, though.
Well, and I'm happy to answer questions. I know people are kind of apprehensive about what this move to 10-CM is going to be like, both from the medical coding world as well as from the data and analysis world. The medical records coders are needing to spend a lot more time being able to code this level of detail, and if the level of detail isn't available in the medical record, that can be problematic. And then for those of us who analyze electronic data sets that have been coded in these new systems, it will be a learning experience for sure. In my lifetime, I haven't gone through a transition like this. My working life has all been in ICD-9-CM, so we can't even get advice from those who have been through it, because I don't know that there are too many of those folks available to provide wisdom on this. So I think we're just going to have to work on it together.
Thank you.
All right. Well, thank you, everyone. This has been really one of the best webinars I've ever participated in, and very useful information to all of us that work in brain injury in some way or another. Just a reminder to folks, check back next week at the NASHA website for the recording from today's webinar, and hopefully the slides and additional materials and links. We hope you'll register and join us for the next webinar that we're having coming up this month, Fall-Related TBI Among Older Adults, and that will be held on September 30th. If you have requests for future webinar topics, including further webinars on the ICD-10-CM codes, please send your ideas and requests to us at the email address training@nasha.org. That's training@nasha.org. And please consider joining us for the annual State of the States Conference in Denver, Colorado, October 26th through the 29th. We're hoping for great weather and great attendance out there. Again, thank you to our presenters, and thank you